My name is Lauren DeHost, and this presentation is about reducing the incidence of ventilator-associated pneumonia. Ventilator-associated pneumonia is known as VAP. It is a hospital-acquired infection similar to a CAUTI or CLABSI. VAP is caused by bacteria introduced when a patient is mechanically ventilated. The average VAP incidence rate is 2 to 6 episodes per 1,000 ventilator days, and it can be prevented using the VAP bundle, which we all know is raising the head of the bed 30 degrees, turns every 2 hours, chlorhexidine mouthwash, things like that. How does VAP impact our patients? It increases their length of stay and causes increased mortality rates for ventilated patients. Also, the average cost of hospitalization is increased as well. And for this research proposal, I did a literature review. A study in New Delhi, India, comprised of 60 ICU nurses, studied demographic variables and VAP bundle compliance. Level of experience, education, and in-service education were the variables that were chosen for this study. No correlation was found between bundle compliance and these variables. A 2016 study in Greece followed 362 intubated patients. Staff education over the VAP bundle was implemented over 2 years' time. Results showed increased bundle compliance, reduced VAP incidence, and a decreased length of stay. VAP in-service education was also very recommended by this study. A 2018 study was conducted in Chennai, India, where the VAP bundle compliance was researched after implementation of an in-service education program. After the implementation of the program, post-intervention compliance increased to 94%. The study recommended further need for VAP education. In 2015, an Egyptian study investigated implementing in-service education to reduce VAP rate. In the post-intervention phase, days of mechanical ventilation decreased significantly. VAP incidence rate also decreased as well. I think this is our last study. In 2015, in Beirut, Lebanon, a study was conducted that showed the relationship between level of experience, VAP rate, and in-service education. A training session was conducted where they demonstrated the use of the VAP bundle. The VAP bundle compliance significantly increased after the training and in-service education. So they did like a competency-based training. And here is my PICO question. Annual ventilator-associated pneumonia prevention education for ICU nurses may decrease the incidence of VAP in intubated patients compared to no annual education. And then I based this research proposal on Benner's from novice to expert theory. Benner's theory focuses on a model for the stages of clinical competence for nursing. Nurses gain knowledge and understanding by increased experience and education. And then here is the design, the setting, and the sample. The design of this research would take an experimental approach. Half of the ICU nurses on a 30-bed unit, intensive care unit in southern Indiana would be educated, the others would not. Incidence rate would be collected pre-intervention at the 6-month mark and at the 1-year mark. And here is the data collection and analysis. VAP incidence rate is the instrument of data collection. It is valid because it's an objective measure. It's also reliable because it's calculated the same way each time. A chi-square test was used in a previous study that I explained further back in the presentation, and they found that that was useful. Therefore, I would use a chi-square to measure the significance of the data. And then in conclusion, VAP is a hospital-acquired infection that greatly reduces favorable outcomes for our patients. It increases mortality rate, it increases length of stay. Prior research has shown that by implementing VAP education, we can decrease the incidence of VAP in our hospitals. And by decreasing this incidence, we can improve quality of care for our patients. And that is the end. Thank you.